The manuscript I will be discussing is titled Axillary Nodal Response to Neoadjuvant T-DM1 Combined with Pertuzumab in a Prospective Phase 2 Multi-Institution Clinical Trial. There are ongoing trials examining de-escalation of systemic therapy for HER2-positive breast cancer patients. Of course, the concern for us breast surgeons is that we can still perform sentinel lymph node biopsy after these experimental neoadjuvant systemic regimens. My colleagues at Dana-Farber Cancer Institute ran this trial that administered 6 cycles of neoadjuvant trastuzumab and tansine, or T-DM1, plus pertuzumab to HER2-positive breast cancer patients. The trial showed that tumors with heterogeneous HER2 staining did not experience a PCR. They had a 0% PCR rate, whereas those with non-heterogeneous HER2 staining had a 55% PCR rate. So, tumor HER2 heterogeneity was discovered as a fascinating new marker of treatment resistance. My colleagues and I then set out to examine the nodal response in this trial. And what we found was that all CN0 patients with a breast PCR or residual cancer burden of 1 were YPN0. Similarly, all CN1 patients with a breast PCR experienced a nodal PCR. So, breast response and nodal response were very tightly correlated. These findings support axillary surgery de-escalation, including in the context of systemic therapy clinical trials. For example, one should feel very comfortable performing sentinel lymph node biopsy after neoadjuvant therapy for CN1 patients. But even more than that, there are new trials in Europe looking at using neoadjuvant therapy for patients with node-negative, HER2-positive, or triple-negative breast cancer, then performing breast imaging or breast surgery. And if there is a complete response, or in the case of the lumpectomy, a breast PCR, then they are omitting axillary surgery altogether. The results from our study support these exciting trials.